I'm Rebecca Grant. I'm the author of Birth, Three Mothers, 9 Months, and Pregnancy in America.
Yes, thank you for joining us and for the book. It was quite interesting. Could you maybe begin our discussion with how you came to write this book and what you learned while you wrote it?
Sure. So I'm a journalist and I've covered reproductive rights and health and justice for about 8 years at this point. I'm a freelancer, so I mostly do magazine and kind of long form pieces. And so in 2018, I published a story that was about women and families in Alabama who were crossing state lines to give birth with midwives because Alabama had these really restrictive midwifery laws. And so if you wanted to give birth outside of a hospital, you basically had to leave the state. And that was sort of the project that really sparked my obsession with midwives and ultimately led to the book. And so the book is set at a birth center in Portland, so it's not looking at families who are going out of state, but it does focus very closely on a few main stories and really looks at why people make the birth decisions that they make, why they seek out midwifery care in this case, and weaves those kind of very intimate narratives with history and context and research that looks at not only midwifery care, but really kind of the landscape of maternal health care across the country.
Yeah, and I think could you begin by laying out what you discovered when you started looking at maternal health care, pregnancy, and birth in the United States across the country?
Yeah, I think one of the reasons that I first started reporting on maternal health care, so when I first started out on this beat, I was really focused primarily on abortion rights. And the more that I reported on abortion rights and the more that I interviewed and spoke to folks who were sort of in that movement, the more I came to understand and learn about how intimately connected abortion rights are and kind of reproductive autonomy and freedom and those questions with maternal health care. Because the same people who get abortions are the same people who go on to have children and vice versa. And it's all kind of part of the same continuum. And so once I started reporting on maternal health care, one of the first things that I learned was about the racial disparities in maternal health outcomes. So not only did I learn that the US has pretty poor maternal health outcomes overall as compared to peer countries, but also the real driver of that are racial disparities, which have been pretty consistent for a long time. And sort of the CDC statistic is that Black women are 3 to 4 times more likely than white women to experience maternal mortality. And so I think that once I kind of learned some of those very dire statistics, but then also was really learning more about kind of the way that our maternal health care system was structured, and then some of the folks who are a part of that system who were trying to do something different or kind of offering a different model, in this case, midwives, but also doulas too, I really became interested, not just in maternal health care overall, but kind of in that like almost subculture or subsection of the system.
And I was interested to learn I was interested to learn that pregnancy, I mean, when you think about it, it's so common. So it does make up a huge chunk of American healthcare. And one of the statistics in your book, which I wrote down, was that like 23% of hospital stays are related to birth or maternity. And also 6 out of 16 most common procedures are related to birth. And maybe you could walk us through how we've gotten to a hospital model versus some of these more organic ways of having, birth and maternity care.
Sure, yeah. And something even though the book is primarily focused on midwives and birth centers, something that I tried to be really thoughtful about was not to deride hospitals or the amazing work of OBGYNs in any way. I mean, the vast majority of babies in the country are born in hospitals and doctors have an extremely important role to play. However, the fact that our birth that the norms for birth in the US is very hospital centric, is very OBGYN centric. The kind of high rates of medical interventions that we have as a standard part of care, that isn't necessarily kind of in line with what some other peer countries do. Midwives are much more integrated, and they might be integrated into the hospital, but they're a much more integrated part of the care in places like the UK or many Scandinavian countries. And so in some ways we are a little bit of an outlier in the ways that midwives have kind of been marginalized by the mainstream maternal healthcare system. And so a lot of that goes back to history. When the kind of American medical kind of establishment was really formalizing in the mid 1800s, there was a really concerted effort on the part of physicians who were sort of in that tradition that we now think of as being like Western medicine or allopathic physicians. They were trying to kind of move away from sectarian medicine, in which there were lots of different types of providers or physicians. And they were kind of moving towards something that was more central. And part of that was a campaign to really stamp out midwives and midwifery. And so, you can read, there's all of these articles from the time that, midwives are sort of being cast as evil and ignorant and dirty and illiterate and abortionists and like all of these sort of very seemingly scary things. And a lot of that campaign was very wrapped up in racism and misogyny and xenophobia, because the midwives were predominantly in the Northeast and parts of the Midwest. It was immigrant women who had trained as midwives in their countries of origin and then brought those skills with them. And then in the South, it was predominantly African American grand midwives who were part of this much longer tradition. And I think part of what's interesting is that the transition from kind of out of hospital and midwives to in hospital with physicians, that happened faster in other parts than in some parts of the country than in other parts. And kind of the slower transition really did happen in the South, because the reality was that a lot of those, white hospital-based doctors didn't want to serve those communities or were unwilling to. So, I think there's been like a lot of it's interesting, I think, to find that some of the things that characterize our modern day system, you can really go early back into kind of the history of medicine in the US more broadly and see some of those threads that are really, pretty consistent over the decades and centuries.
Yeah, and that's one of the things that I've been doing in the last couple months is tying those threads together. And this book really kind of fits nicely into that, because I think we all have an idea of what birth was before hospitalization and what a midwife could do or was doing prior to this professionalization of hospital standard. But if you could tell us what is a midwife? What did they do prior to, like, even let's just say prior to the 30s, when, what did it look like to give birth with a midwife?
Yeah, so, going back a while, it was really a very home-based practice. This was sort of, even thinking about before there were hospitals in any kind of a meaningful way, but midwives tended to be respected elder women in the community. And so often they had their own children, and maybe that chapter of their life was behind them. And so that then they had that experience and they were really focused on serving other women. And, in some communities, or maybe in all, it was a really, tended to be a really respected position. And midwives were people who, they would not only show up to kind of quote unquote catch a baby, but in some cases they would stick around after. They would, women kind of had communities around them who were being supportive. And it was, a very kind of simple practice. And I don't say simple to mean that it didn't take an incredible amount of skill, but just in that there weren't a huge amount of like tools and instruments that were involved. And so one of the things that was happening as there was some more medical technology that came around, but then also as male doctors kind of started to be interested in getting involved with midwifery is that they started to introduce tools and instruments into the delivery room, even if they were delivering at home. So like they might be more likely, for instance, to bring forceps and to try to introduce those into birth. And so it did kind of effectuate this transition from something that, a midwife might do and remain relatively hands-off or kind of use their hands and to something where there were more instruments involved. And, in some cases that could potentially be helpful, but especially before there were, hygiene protocols and kind of awareness of the way that germs work, sometimes the use of those instruments could do harm than good. And I think that that's like a really common theme as well through the book, and something that is still kind of being ironed out in some ways today, is that more technology, more kind of medical interventions isn't always better. In some cases it is, and in some cases it can be life-saving, especially now that we know about, sterilizing things and keeping them clean. But that hasn't necessarily always been the case. Like more is not always more. And so I think that there's some kind of interesting I think there can also be a tendency among folks who are really supportive of midwifery to kind of criticize any and all medical intervention as being negative or bad, or no one should be having C-sections or something. And maybe no one's actually really saying that, but C-sections are kind of a good example because they can be a life-saving procedure, and it's extremely important that people who need them have access to them. But when they're overused, they can do harm. And so that got a little bit off track, but sort of the practice of midwifery did tend to be a kind of community-rooted home practice that was something that kind of women would handle together. And over time, once it moved out of the home, and then it was predominantly something that male physicians were working on, it was sort of something that a woman went from doing, or a person went from doing, to being something that happened to them in kind of a foreign environment, and in ways that could be scary and isolating and alienating.
Yeah, and I think that move is incredibly interesting and speaks a lot to the patriarchy and white supremacy and some of that I want to return to. And I want to return to C-sections in a minute. But before we move off of midwifery, I want to talk about Breckenridge and who she was and how she kind of brought to America the British model that existed between the wars, right? It was like this innovative jump between World War I and World War II, and then again after World War II, because war innovated very quickly some of these professional standards and ways of doing surgeries and things like that. But if you could talk about Breckenridge and who she was.
Yeah, so she was she was the person who kind of started, I think you could say, the profession of nurse midwifery in the US. And so there are kind of today two main buckets of midwives, and it can get a little bit more nuanced than this, but for the most part, you have certified nurse midwives who are nurses who have received or earned a midwifery credential. And so most of they're kind of, the acronym is CNM. Most CNMs practice in hospitals. And so, they are trained in sort of a medical clinical model, right, of nursing, but they're midwives. And, that is the model that I mentioned before, that you often might see in European kind of hospitals. And then the other category, there's a whole bunch of different words you can use: lay midwife, direct entry midwife. The credential that most people have or associate with that category is certified professional midwife, or CPM. And so you do not have to be a nurse to earn that credential. It's a different educational track. And so those midwives that I was speaking about before, the immigrant women and the grand midwives who were practicing in the South, they were mostly part of that lay midwifery tradition. They learned through apprenticeship and through doing. And so Mary Breckenridge was a nurse, and she came from a very wealthy, politically connected family in Kentucky. And so she went to Europe, where she was, as you mentioned, sort of in the wake of the war. And she was really inspired by some of the nurses and the nursing models and the specific midwifery kind of models that she encountered over there. She spent some time in France and in England. And so when she came back to the US, she really wanted to bring that sort of like professional nurse model of midwifery to some of the poor communities, and sort of thought it was a really powerful way to bring healthcare to rural communities. Part of her vision, as I think you sort of alluded to, certainly had eugenicist overtones, or like, overt, was super overt, like in the campaigning and sort of the fundraising that she would try to do. And so part of that was like, we want more white babies, but she, built this kind of cadre, this group of nurses and nurse midwives who traveled all over. They were referred to as angels on horseback. And, they would schlep so much stuff. Like they would have all of this gear, and it was like really heavy, and they would ride to these really rural areas and provide healthcare. And so certainly, maternal healthcare and delivering babies, but then also over time really expanded to provide a whole lot of other types of care. And I think, in some ways that speaks to, the really exciting potential that midwives, and sort of untapped potential that midwives have to provide healthcare in rural communities, which are facing, pretty dire shortages of access to maternal healthcare. But then, Mary Breckenridge's legacy, like, now they're, the school that was that she initially created to train more nurse midwives, because initially people were training in Europe and then coming back and working in the US, like that school and kind of, an adapted form is still open today. And so what ended up happening was that CNMs, or like these nurse midwives, they were primarily kind of educated, or at least middle class white women. And then the lay midwives were predominantly women of color, and in the South, Black women. And there was sort of this hierarchy that happened where the CNMs, or CNM, I shouldn't say, because that credential didn't exist at the time, but the nurse midwives were kind of in these public health oversight roles, and they would work kind of over these lay midwives, which in some ways in the public health system was helpful, in that they were able to teach certain things that they had learned through their medical training, but then in other ways was also kind of, paternalistic and patronizing. And so there have been, historically some tensions between the nurse midwife group and the lay midwifery group, even though, they all are part of this midwifery tradition.
Yeah, thank you for that. And I guess we should probably talk a little bit more, or we should move into the doula, and how a doula, what it is, and how it differs from a midwife, and how it differs from an OBGYN.
Yeah, this is an important question, because I feel like from people who, maybe they're just friends or they don't know very much about this, and people are always very confused about the differences between midwives and doulas. So I'm glad that you asked. This is super oversimplified, but like a way that I've heard other folks talk about it before is that doulas will handle kind of things like above the waist, and midwives will handle things below. And again, that's pretty reductive, but doulas are really there to provide continuous emotional support. And that can look like different things. And that could mean something like a massage, or, something that is tactile. Whereas midwives, really, whether they're a lay midwife or a nurse midwife, like they're there to help attend the birth and catch the baby, as midwives like to say. So they're really there in more of a kind of delivery, I guess, capacity, whereas a doula, that's not their role. The doula is there to provide this continuous emotional support. There's a little bit, some folks view their role as more of an advocate if they're a doula, particularly if they're working with clients who come from communities who have kind of historically been disadvantaged or discriminated against within the mainstream healthcare system. So a doula might be able to kind of interrupt harm, or they might see their role that way, whereas others don't particularly view that as their role. And it's really more about being there for someone, of being someone else that someone who's giving birth has in their corner. It's about helping to answer questions, or just, even like navigating questions of like, when should I go to the hospital, or when should I go to the birth center? And like, those might be questions that your care provider answers or addresses for you, but I think it's very different when you're actually going through it in the moment. And so I think that doulas have, the kind of idea in the modern form has been around since the 80s, but I feel like over the past 5 years, probably longer, there's been this real kind of national growing in awareness of the role role that doulas can play. And so doulas can work across environments, hospital, birth center, home. There's some amazing community organizations that offer kind of a sliding scale model. If affordability is an issue, in some cases, hospitals or other practices might have doula programs that are kind of part of their organization to offer to people. And there's some really amazing research about the power that doulas can have on birth outcomes and experiences. So that continuous emotional support, it might seem simple or trivial or like it's not that big of a deal, but it really does have an amazingly powerful impact in a way that's been documented by research. And so, something I tried to do in the book and then I'm a firm believer in is that there's no best way to give birth, right way to give birth. One environment or care provider type isn't better than another. It's really about what's right for you. But I do think if there was sort of going to be a piece of advice that thinking about a doula or finding a doula who you feel like is sort of will be there in a way that is helpful is something that I think, assuming that the sort of resources are there, that everyone can really benefit from.
Yeah, and there are quite a few doula programs here in Cleveland that are picking up steam and making inroads into more low-income communities. And I think that, as you were saying, that navigation of the system is incredibly important. And, you mentioned the book that a doula will save Medicaid typically $1,000 per birth by just being there and kind of navigating and calming and talking people through some of the systems. But I want to talk now, move into kind of the racial biases of the healthcare system and how birth looks different to a white middle class person, a Black middle class person, and someone who's lower class of both, and how what you found in your research for the book and also what you saw on the ground.
Yeah, I mean, as I mentioned before, that sort of learning more about maternal mortality and racial disparities in maternal mortality was something that I learned pretty early on as I kind of started to become more interested and pay more attention to maternal health care. And I will say something that, the birth workers and the advocates and activists that I spoke to have always emphasized, and is important to emphasize, is that while those outcomes and those disparities are definitely alarming and really tied in with racism and something that to be really cognizant of, I do also think and know that it's very important to be aware of the fact that everybody is equally deserving of the opportunity to feel excitement and celebration and joy around their birth experiences. And so it's just also important not to kind of focus so much on it's also important that that's not the only story that's being told about what it looks like for someone to, especially, a person of color or someone who is from a community with some of these disparities and outcomes, to not just kind of focus on the negative is, I guess, what I'm trying to say, as I'm about to talk some about the negative. But yeah, I mean, there's kind of a chapter in the book where I really dig into this, to the maternal mortality rates. And one of the things that's so complicated is that it's all completely connected. Everything, you can't just point to one factor. You can't just kind of pull on one thread and have that be the really simple explanation. I mean, you sort of can. There's a quote in the book from Dr. Joya Crear-Perry, who is this incredible doctor and also speaker and the founder of the National Birth Equity Collaborative, which is an amazing organization. But, she has talked a lot about how sort of the risk factor isn't race, it's racism. And so when you look at these factors, it can be things like access to health insurance and access to healthcare. It can be discrimination in the healthcare system. It can be who is more likely to live in a food desert, who is more likely to live in an area where there's going to be lead in the drinking water, or there's going to be extreme heat, right? All of these, there's these external environmental factors, but who is more likely to be exposed to those is going to be related to race, as we know. But there's also this research that shows that even when you control for education, for socioeconomic status, for for income, like for all of these things that we should sort of think as being somehow insulating or protective factors that would lead to improved outcomes, you don't actually find that. So even when you control for those factors, the racial disparities are still really stark. And so something that I talk about in the book and is this idea of weathering, which was initially kind of developed by this scientist and researcher named Arlene Geronimus. And I actually think she might be working on a book about the topic, but I'm not 100% sure, but I think I heard that. Anyway, and it's this idea that being exposed to kind of relentless chronic stress can take a toll on the body. And so, there's this whole kind of scientific concept around the allostatic load and like how much stress your body is taking. And that can kind of cause this wear and tear that can not only cause chronic disease, but that can also lead to it just takes a toll on the body in a way that can make it harder to have a healthy pregnancy. And so even if you're someone of means and you have all these resources available to you, if you're a person of color or like, for this conversation specifically, a Black person navigating life, like that chronic stress can have an effect in a way that you can't avoid. And then that can sometimes for some people translate into these birth outcomes. And so then if you're entering a system in which you're not taken seriously, in which your pain is dismissed or ignored, in which you're being discriminated against, in which they're trying to like rush you through, like whatever form that discrimination might take, you're kind of having this mismatch of things. And so it's like a combination. The phrasing is sort of like too much too soon and too little too late, where you might be subjected to kind of medical interventions or procedures that you don't necessarily need, whether that's in an effort to like speed things up or whatever the case is. But then also if you did need some sort of a treatment for a complication, that maybe people aren't paying attention to you. But even like super famous celebrities like Serena Williams and Beyonce have talked about how even when they were navigating their pregnancy or birth experiences, they had moments where they felt like their healthcare team wasn't really listening to what they were saying about about their bodies, and like that could have had really dangerous consequences. So it's a very tangled, complicated web in which an entire book can be devoted to that alone. And so in my book, there's three main characters, and they're all kind of pursuing out of hospital birth in Portland, Oregon, where I live. And so one of the characters, Tamika, she is a nurse, and she had always loved the idea of being a labor and delivery nurse, and that was her ultimate goal. And so what I found was really interesting and compelling about her story was that she, as a professional, wanted to work within a hospital birth environment, but as a patient, as a pregnant person, she wanted to give birth outside of the hospital. And ultimately, the reasons underlying those two things were the same. Like she was a really like a curious person who loved to read and learn more about all of these issues that I was just talking about. And so for her job, she wanted to be that person in the hospital who, if other patients came through who looked like her, like she could provide all those sort of bells and whistles. Like she could be the nurse and the care provider there who let them know that they were seen and had their back and took them seriously. But then as a patient, she really wanted to be in a place where she felt like she wasn't going to have to like fight for everything or sort of worry about how she was being cared for. And so I thought that kind of that approach was really, really interesting. And one of the many reasons why I was drawn to her as one of my main characters.
Well, I'm glad you brought her up too, because it leads into what I wanted to talk about next, which is cesareans and the C-sections. And that's how she ultimately has to give birth. And I think talking about how C-sections function in a hospital, how they just the whole thing, because it seemed like when my niece was born 14 years ago, 17 years ago, everyone was born C-section. Like everyone in that hospital was getting C-section. Nobody was having natural births. And that was just, it was either coincidence or they were actively pursuing it. I think you talk about in the book that, it varies from 7 to 70%. So yeah, talk about C-sections and what they are.
Sure. Yeah. So as I said before, they're a life-saving procedure in certain situations, and it's like an amazing thing that we are able to provide C-sections to the people who need it. But right now, the C-section rate in the US is about 1 in 3 people have a C-section, and the World Health Organization, which has looked into this and sort of has a recommendation where they basically say, I think it's 15 to 20%. It might be 10 to 15, but let's just say 15%. And that's sort of the threshold that's a good threshold to aim for. Because if the C-section rate is below that number, that could mean that there are people who need that surgery who aren't getting it, which can be extremely dangerous because there are absolutely cases in which it is necessary. But if the rate is too far over whatever that window is, 15 to 20%, that can also mean that there are people who are getting the surgery who don't need it. And performing a C-section on someone who doesn't need it or want it is not like a neutral act, right? It's major abdominal surgery that you're performing on someone who, is sort of at least relatively young, right? And so the recovery can be really difficult. And some people, their recovery is okay, but certainly I have interviewed so many folks where they just had a really arduous recovery from a C-section. It's a major abdominal surgery, right? So just like any surgery, there's going to be a recovery. There can be a higher risk of complications, whether that's infection or whether the wound is opening. And so, it's not that vaginal birth doesn't have any sort of recovery involved, certainly depending on how it goes, but it's different than having kind of a major surgery. And so because C-sections can have a higher rate of complications, it just emphasizes, and because the recovery can be really challenging, it's sort of why it's important to make sure that the only people who are getting C-sections are the people for whom it's medically indicated. But one of the really big challenges is that it's not always clear, and different physicians and different hospitals won't necessarily agree on when it's medically necessary. And so, there's a couple examples in the book, but whether that's kind of because labor is being perceived as taking too long, or whether it's because a baby is perceived to be too big to birth vaginally, all of these things. Some cases may or may not be true, but one physician at one hospital might make one call and one physician at another hospital might make another call. Or it could be the heart rate strip. If someone's having fetal monitoring, it may be that the heart rate is dipping. And so then you make the recommendation to perform surgery. And so I think that was to the question I think you kind of opened with of things that I learned or things that surprised me. I think not being a medical person myself, I had always kind of thought that medicine was fairly black and white. And maybe that's a relatively naive view, but it's, of course, doctors get so much schooling and they learn so much. And I think one of the things that was so interesting and felt a little bit revelatory was that there is so much, not just in maternal health in all medicine, but in this case, maternal health, where it's not actually black and white, where different doctors make different calls. I guess that's why people get second opinions. And so the idea that in some cases there isn't a really clear objective, this is absolutely the right thing to do, that it's often much murkier than that. That is part of why I think that the C-section rate can vary so widely, because a lot of it, as you touched on, depends on the sort of culture of the hospital. And so, if a hospital is extremely conservative in terms of liability concerns, they might have a much higher C-section rate because there's this perception that if you do a C-section, it's lowering the rate of a malpractice issue because you've sort of done everything that you could. If it's a much busier hospital, C-sections are faster, so they might be more likely to perform more of them because they're trying to kind of have more patients go through there. There's even a study that talks about cost orientation because C-sections are much more expensive. And so I believe it was a study that was done in California, which found that if you change the sort of profit incentives around C-section versus vaginal birth, it did actually have an effect. And, I don't think that these are things that most physicians are sitting there thinking about, cost and efficiency and liability and all of those sorts of things. But there's sort of the subconscious effect, and there's the culture of the hospital, the things that they're sort of being told to do or that are kind of recommended by the administration that absolutely shape behavior. And so that's part of it. And so for a patient who is like really hoping to avoid a C-section, which, you know, some people, they're sort of like, if it happens, it happens. If it doesn't, it doesn't. Some people would request it. You know, those things are all fine. But for a patient who's interested in trying to avoid one and they're having a hospital birth, it's really good or important to try to find out, like, what is this hospital's C-section rate and sort of what are their policies, and like, are there certain cases in which they will like require me to have a C-section? You know, like some hospitals, for the most part, like if you're having a breech baby or multiples, like you'll sort of automatically be recommended for a C-section. And so I just think it's like a good question to be asking, so you kind of understand what, in some way, like the kind of likelihood is, if that's something you're trying to avoid.
Yeah, and before we wrap up, because I don't want to take too much of your time, I would like to talk about death and maternity, because one of the things that is really happening here in Cleveland is we have a very high infant mortality rate in the city, and we have some of the best hospitals in the world, supposedly, right? Cleveland Clinic and University Hospitals, and we have this incredibly high mortality rate. And secondly, it seems like the argument couldn't be made that this is what biology is meant to do. So why are so many people dying from giving birth, and why are so many babies dying? So I talk about it in the book, and pregnancy is very dangerous as well as it's very natural, and it just doesn't seem to, you know where I'm going with that.
Yeah, I know. And it's sort of this interesting thing. And it's kind of like what I was saying before, too. It's like there's sort of this fine line between saying that, like, you know, this is what the body is sort of meant to do. Because I do think, like, even though I'm focused on midwifery care in the book, and because for people who are giving birth outside of the hospital, they're doing it without epidurals, like that's sort of what midwifery care looks like. But there can also be this tendency among the kind of quote unquote like natural birth movement, I think, to treat any medical intervention as negative or like as some sort of a failure, or to portray an unmedicated birth experience as somehow like morally superior or more authentic or something. And I certainly don't think that's true. I think that, you know, a C-section birth can be just as moving and meaningful and perfect for that person as, you know, a home birth in a tub or whatever it is. And so, you know, on the one hand, I sort of totally get that statement of like, it's what the body is meant to do. Like pregnancy is a crazy thing. Like all the ways that the body changes and adapts to it are just absolutely wild. And like, I don't have children. I've never been pregnant. So it's not something I've navigated myself, but I certainly have friends, and then through the reporting. And I feel like even now, even though the book is out, I'm still learning things that other people are experiencing during pregnancies that kind of blow my mind. Like it's just the ways that the body changes and adapts are just, I think, so fascinating. And yes, pregnancy can be dangerous. It can be super dangerous, but there's also all of these things and these medical advances and these ways that we're able to make it less so. And so ultimately, I don't even know, maybe I got a little bit off topic, but I just think it's sort of like, that's part of what's so interesting, I think, about reporting on this space, but also for people who are navigating it, is like you're kind of having to hold all of these things together. All of these things are sort of trying to coexist. And I think that all of those tensions are part of really what drew me to the subject, because you're going through this thing that's incredibly momentous, and it's also incredibly mundane. And you're going through something that's like the happiest, you know, apparently like one of the happiest things you're ever going to do, but it's also absolutely terrifying. And so I just think all of those tensions are really interesting. Anyway, that was a little bit off topic from sort of the question of infant mortality. But I mean, you know, many of the things that I was talking about before that contribute to maternal mortality and racial disparities, you know, those are certainly related to factors that have an impact on infant mortality. Like for the most part, those things go together. You're not going to find like really high rates of infant mortality, but super low maternal mortality. I mean, they do kind of coexist or go together for many of the same reasons, right? I mean, it's sort of about like the health of the person, which can be affected by all kinds of sort of other conditions. And so ultimately, I think this is going to sound very simple, but like the healthier that people are, and I sort of mean that in what I hope is sort of a holistic way, like the better that they're treated, the more access they have to health resources, the more ability that they have to like access good food, or to be able to get outside, or does not live in a state of chronic stress ultimately. And then if they can navigate a system that really does care for them, and that is sort of using these medically kind of evidenced best practices, like all of those things, which are incredibly complicated, kind of actually on the ground, will help address these issues that are really thorny and kind of intractable, or can sometimes feel that way, but I really don't think that they actually are.
Yeah, and I really liked the book because it really showed in some graphic detail some of the there's some things I won't forget, but the like that, as you were saying, the biology and each pregnancy is different and unique, and but it can pose wonderful opportunities, and people are very like my sister had prenatal diabetes, and that was very rough on her, but not everyone gets that. And why do some people get it first? So I can understand where the medical community gets very confused, and maybe you're only having one kid, so you only do it once, and then that's your only experience. And I think that kind of leads me to you point to, at the end of the book, some prescriptions for how maternity could change in the United States and how we can make it better. And I'd love to kind of walk us through some of that.
Yeah, absolutely. I mean, some of them I think I just touched on a little bit in my previous slightly off-topic answer. But I think, access to healthcare and also to things that help promote general health, I think, are super important. Medicaid expansion, absolutely. So, to make sure that folks from all kinds of incomes are able to access, the services they need, like preventative care, like being able to like see a care provider when you need one, can be really important, as is, stuff like clean drinking water and access to healthy food and all of those things. So I just sort of think anything that can sort of promote general health, but then also address these underlying systemic reasons why some folks have much better access to kind of those things that could make them healthy than others, or receive treatment for kind of chronic illnesses. All of that's really important. I think that there's sort of an effort to standardize certain kind of medical like complications or situations in some way, which I talk about in the afterwards. So there's these kind of like safe maternity care bundles in which it's sort of like, this is, best practices for treating hemorrhage or whatever that is. And so, standardization can be tricky because on the one hand, a one size fits all model isn't right. And that's sort of part of what the book is trying to say, like, this isn't great. But then on the other hand, because of some of that nuance in that gray area that I was talking about before and how certain decisions are made, it can be really important to be like, when an emergency is happening, we're doing X, Y, and Z, or like, this is the standard way to handle it if someone has a condition like preeclampsia, which can be super dangerous. So making sure that like, if someone has a certain blood pressure reading or these certain signs, that it's actually being treated in the way that it needs to be. I've interviewed folks, not for the book, but for an article I was working on, where there was a patient who had all of these really like clear signs of preeclampsia, and none of the physicians flagged it or sort of did these basic things. So like, that stuff does happen. So bundles like that. And then, obviously, the book is focused on midwives and birth centers, and certainly I don't think that they're a panacea. And I also completely recognize that the overwhelming majority of people in the US give birth at hospitals and probably will continue to do so. But I certainly think, through my reporting and sort of my years on this beat and reporting this book, that improving access to midwifery care, and really specifically to community midwifery care, could be a really important part of the puzzle. And so we're seeing like a lot more kind of community organizations, whether that's doula groups or birth centers or midwifery practices, or even just sort of like general reproductive health support organizations that are opening. And I think that those are really amazing and inspiring and need to be supported, because they understand the specific needs of the communities that they're in. And so they can sort of really gain the trust of those communities, but then also understand what those intersectional needs are in a way that's really specific. And so, again, it's like once you pull on one thread, there's all of these other things, because how do you make midwifery care and birth centers more accessible? And that's like making sure that there's insurance coverage, both public and private, for people who want to give birth outside of a hospital. It's like making sure that midwives that people from a diverse group of backgrounds, whether that's racial or socioeconomic or geographic, are able to train as a midwife. Midwifery training, whether you're doing the CNM or the CPM route, like there can be educational barriers that are there that can make it difficult. Opening a birth center, like in some states, they make it extremely difficult to do that, or even for midwives to practice in the first place. So, ultimately the sort of list of prescriptions could really go on and on and on. But I think aside from that stuff I was talking about just kind of like generally promoting health, it's trying to figure out how to build a system where each person can give birth in the right environment for them, with the right type of care provider for their needs, and then sort of, be able to be treated well. Like I think how people are treated has a big outcome, or has a big impact on their birth experiences. It's not incidental. It's not like a nice to have to be treated well or to not feel like you're being treated badly as you're going through this experience. And, birth is unpredictable. That's one of the other things that's fascinating about it. So just being able to have a system that can kind of adapt and respond to that. And so, in advocating for greater access to midwifery care, one of the things that's important is ensuring that midwifery care is integrated into the mainstream or the hospital-based system. And so midwives need to be able to transfer their clients to hospitals as needed, and they need to be able to do so without fear of law enforcement or without being, really mistreated by the people at the hospital, which is certainly something that you hear of. And, there needs to be discussion between these two types of care providers, right? Like if someone transfers to a hospital, the doctors or the nurses on that side need to know what's going on with that patient, and that midwife knows. So they, there has to be this ability for patients to sort of move through the system and access the different kind of levels of care that they need at different times. And so I think, integration and sort of all the many things that entails is also part of it. So yeah, I think, even just like locally in your area, if there are some community birth organizations or midwives or doulas or just kind of like reproductive justice or freedom groups that are talking about some of these things, like that would be great for people who are interested to look into, because there, are birth workers doing some really amazing work all over the country, and doctors too, of course, OBGYNs. And so, yeah, I'm sure there are some really awesome folks doing some cool stuff in your neck of the woods.